introduction. So thank you.
Excellent. Thank you.
Well, good morning, ladies and gentlemen. It's exactly 7 a.m. and I am absolutely delighted today to have our keynote Grand Rounds speaker here with us. We are all in for a delightful treat. We are truly in the presence of nephrology royalty here. I have had the absolute privilege and honor of knowing Dr. Navaneethan back from our Cleveland Clinic days for nearly 15 years. He has been an amazing friend and colleague who has soared to unbelievable heights in the field of nephrology. And we're also delighted to have him here today virtually. Unfortunately, weather has interfered for us to have him here in person. He's currently in Houston, Texas, which is on Central Time. So this is a little bit on the early side for him. But I don't want to take more time away from his presentation because in an introduction of Dr. Navaneethan, I believe it would take at least 2 hours to fully encapsulate really what Dr. Navaneethan has done in the field of nephrology and who he has been with promoting nephrology, not only nationally, but internationally. So briefly, Dr. Navaneethan holds the Garaband Aknoyan MD Endowed Professorship of Medicine, which is a tenured position. He serves as an associate chief of the section of nephrology, chief of the renal section at the Michael E. DeBakey VA Medical Center, and is the director of the resources core at the Center for Translational and Precision Medicine Health within the Institute of Clinical and Translational Research at Baylor College of Medicine in Houston, Texas. As a clinician scientist, his primary research interests include clinical trials in diabetic kidney disease, the impact of obesity and intentional weight loss on chronic kidney disease, cardiovascular complications in kidney disease, health services research, and systematic reviews in nephrology. He is a pioneer in the use of electronic medical records to enhance care for kidney disease patients and has authored hundreds of peer-reviewed publications. He is actively involved in numerous clinical studies, has secured independent funding from the NIH and VA. He is an associate editor for the American Journal of Kidney Diseases and serves on the editorial boards of other prominent nephrology journals. He chairs the NIH KEDD study section, holds various committee roles within the National Kidney Foundation, including chair of NKF spring clinical meetings for last year and this year, is co-chair of the KDOKI commentary on KDIGO chronic kidney disease guidelines, and is a member of the American Society of Nephrology guidance statement on obesity and kidney disease, American Heart Association Epistats Committee, KDIGO diabetes and CKD guidelines, and VA Department of Defense chronic kidney disease guidelines. Please join me in welcoming Dr. Navaneethan. And I thank you so much, my dear friend, for being here with us today and sharing with us your knowledge. So thank you so much.
Excellent. Thank you so much for the kind words, and thank you, Dr. Taub and Michael, for kind invitation. I'm sorry that couldn't make it in person. Certainly, we'll miss that opportunity. But of course, we see the weather has so many impact, and hopefully, we'll all keep the people in California in our thoughts and prayers. And again, Happy New Year, everyone. So hopefully, it will be a good start, even though it's bumpy for some people there. So. All right, so I will start sharing. Hopefully folks can see here. Excellent. So in the next 45 minutes or so, I would cover where do we stand with advances in the testing for chronic kidney disease and staging of kidney disease. Especially, I'm not sure if there is access to measuring cystatin C routinely at your center, and how do we best utilize some of the risk estimation to counsel patients. Number two, give you an overview of how best to utilize some of the old and novel kidney and cardioprotective medications in the kidney disease population. and review both 2022, specifically the diabetes kidney disease guidelines by KDIGO, and the 2024 CKD guidelines that just came out about 6 months ago. And this is my research hat. The last one is the consequences of underutilizations. While the guidelines state that use these medications, how often these medications are utilized, and what are some of the consequences of underutilizations of the kidney and cardioprotective medication in this population. This is a graph that shows you the number of people receiving kidney replacement therapy. There is a general recommendation within the kidney community not to utilize renal anymore. The renalism has been discouraged, and it's encouraged to use the kidney replacement therapy. But if you look at the panel on the left side, across the globe, you can clearly see there is a doubling of number, maybe even more than that, the number of people who's on dialysis have received kidney transplant over the past 2 decades. And to your left, you could see that it's split up by the region in which you live. So here is the North America, the blue, clearly showing that there is a steady increase in the number of people receiving dialysis and kidney transplant over the past 2 decades. Certainly, the burden is much higher in Asia, where you see in India and China, the number of people receiving dialysis have steadily and have steeply gone up. So this is not just a problem within the United States, but it's a global problem. Specifically diving into the diabetes, which is the major cause of the chronic kidney disease. If you look at the United States renal data system that tracked each and every dialysis patient, you would see that consistently diabetes continue to be the main driver of the end-stage kidney disease or kidney failure. With if you look at the global burden, it's about like 95% of the population of the type 2 diabetes accounts for the 95%. And majority of the diabetic kidney disease are people with diabetes and kidney disease are coming from the type 2 diabetes. And the most important thing is why cardiovascular disease is much more important in this population is that many of them do not reach dialysis. It's only about 10% of the people with diabetic kidney disease reach dialysis. So how do we optimize their conditions so that the heart failure or atherosclerotic cardiovascular disease, which continue to be the major driver of morbidity and mortality in the population, can be contained? So that has been the focus in the past decade or so, more so with research and for implementation science. Many of you might have seen this. This American Heart Association cardio kidney metabolic health staging was announced in 2023, October or so. This is a presidential address. Most of you, I'm pretty sure, still use atherosclerotic cardiovascular risk score. When you calculate the cardiovascular risk for any patient that's in your office presence or whether they have kidney disease or not, you're more than likely to use ASCVD, which does not take into account the kidney disease status of the patient. So this updated called PREVENT equation, which is widely available out there now, the American Heart Association encourages that the cardio-kidney metabolic risk should be assessed, and you categorize them. These are people to start with have either overweight or being obese. You start with the stage 0, 1, 2, and 3. So there is a nice classification that they have provided. And the risk of cardiovascular disease goes up as you move from stage 0 to stage 3. And this nice figure just talks about like how you categorize them. I'm just going to quickly focus on one thing here. The stage 0 of the cardio-kidney metabolic health means no risk factors, while the stage 1 is excess or dysfunctional adiposity, which is the primary culprit in the initiation of these metabolic risk factors. And the stage 2 is the presence of these metabolic risk factors or kidney disease. As you can see, the kidney has now come in this middle and center, and CKM stage 3 is a subclinical cardiovascular disease and high predicted cardiovascular disease, and stage 4 is overt presence of clinical cardiovascular disease. The whole point of this staging is to identify the risk factors and initiate interventions early on. And if you look at the PREVENT equation, so it gives you an opportunity It takes into account multiple different things, the main things being age, sex, blood pressure, cholesterol, medication use, diabetes, tobacco, and as I mentioned, kidney function, which is primarily the eGFR, it's an estimated GFR. But they also give you an option to include hemoglobin A1C, UACR, urine albumin to creatinine ratio, and the social determinants of health to improve the predictive ability of this prevent equation as far as possible. So going forward, I would see that the community using more prevent equation rather than the ASCVD. So today, most of my talk would be primarily revolving around these two guidelines. To your left is this kidney disease improving global outcomes, similar to the AHA, similar to the ADA. This organization, KDIGO, which has been in existence for now over 2 decades, is a follower of like the old KDOKI guidelines, which first issued the staging of kidney disease. So the KDIGO updated their clinical practice guidelines for CKD in 2024. This is a global guideline. So generally, the KDOKI, which is a which is a product of the National Kidney Foundation within the United States, assembles a commentary group, work group, to issue a U.S. commentary. How does this fit our country, our U.S.? Most countries does this, and I had the privilege of working with many of my colleagues across the country on this U.S. commentary, which also was published just a month ago. Since I will be using a lot of 1A, 2B, what does that 1A, 2B means? The KDIGO follows the grading recommendations of this called GRADE, which comes out of McMaster, just north of Syracuse. The grade 1 means that it's a recommendation. It's a strong recommendation that most patients, most clinicians, and most policymakers would think that this recommendation would make a change in a patient's life. Weak is the level 2 is a weak recommendation, which is we suggest, and A, B, C, D primarily based on the quality of evidence, A being high, B being moderate, C being low, and D being very low. So let me move on. So what is the chronic kidney disease? The definition has evolved over time. It still remains the most important being that CKD is the abnormalities of the kidney structure or function. And it is a chronic condition, meaning it has to be present for over 3 months. So if you see a kidney disease or if you see a abnormal GFR that's below 60, please do confirm within 3 months to ensure that this is chronic kidney disease. The CKD has, again, the primary focus has been on GFR, or estimated glomerular filtration rate, up until 2005, when the KDOKI originally issued a 5-staging system, and the KDIGO updated with a ACR, this color-coded figure. What you see on the left side is the G1 through G5, different classifications based on the GFR alone. And to your right is the A1 through A3, A1 being less than 30 milligram per gram or no albuminuria. A2 is 30 to 299. It's the formerly called microalbuminuria, which is again discouraged. That term is being discouraged by both ADA and KDIGO, because once your albuminuria starts to pop up, it doesn't matter if it's 35 milligram per gram or if it's 400 milligram per gram, the risk is already there. Yes, there is a graded increase in the risk, but the risk of death has already started. So they encourage not to use micro, rather use moderately increased or severely increased. One thing that I want to highlight here is that if you look at the panel here, the G2A3 has the same risk as somebody having a G3B, meaning if your GFR could be 35, but if your GFR is 60 and if you have albuminuria, the risk almost is pretty much equivalent. So the albuminuria has gained traction over the years as a cardiovascular risk marker or risk factor. Targeting most of these interventions that I'll talk about today goes through the improvement in albuminuria. The mechanisms all target the improvement in albuminuria, which precedes the actual improvement in the kidney function. This is a figure more so for primary care and other audience, focusing on what do I do with these patients who fill into these different buckets. The most important thing is like, who do I refer, which I'll talk about that in a minute. But all of them, anyone with any stage of albuminuria would require treatment. And the people with G1, G2, that's the GFR between 60 and above, without albuminuria, you continue to monitor them if they have underlying diabetes, hypertension, or being overweight or obesity, or other cardiovascular risk factors. This is a hot topic. There is across the country, lots of labs have started measuring cystatin C. What is this? It's produced in all nucleated cells, pretty much constantly, and it's freely filtered at the glomerulus. It's metabolized in the proximal tubule. It's an alternate, it's being now considered as the alternate endogenous biomarker to estimate GFR. We don't have the luxury of doing a 24-hour urine collection, which is mostly notorious for errors, or do a measured GFR by injecting iothalamide. When Michael and I were at Cleveland Clinic, we do that in a lot of living donor population, but many centers do not have the opportunity to do that. So creatinine is subject to many issues in people, especially being malnourished. People who have lost their limbs, where I work at the VA here, we have a lot of patients with spinal cord injury, BKAs, and above knee amputations, where the creatinine might not exactly accurately measure your GFR. We recommend the measure of measuring cystatin C, so it doesn't have the bias from the muscle or the underlying health status. This is the formula just to show you how to calculate the eGFR. So when do I test for cystatin C? These are the different conditions which I touched upon. Spinal cord injury with paraplegia, if you are taking care of any of them. If they've been bedridden or have undergone a knee amputation. The reliability of creatinine-based equations in those with GFR above, or in those with BMI above 40, has always been a topic of contention. When people's BMI goes up, it's not just their fat accumulation. There is an increase in muscle mass as well, relatively. How would that impact on the eGFR? No one knows, or at least not being well studied. So in those populations, certainly the cystatin C is recommended. If somebody has cancer, heart failure, cirrhosis, also you could consider them for checking the cystatin C. How does it compare to the CKD epi? So most of the labs across the country have actually moved on now to using the CKD epi equation, especially without including a race factor, which I'll talk about in the next slide. But the CKD epi eGFR equation is the one that's happening behind your screen. Everybody sees a GFR value in your computer, but somebody is doing a math behind it. Doing a calculation behind it. And people have studied this over a couple of decades, that if you use a creatinine-based equation and cystatin C equation, they both independently, if you look at it, they have a good precision. However, if you look at their combination, the creatinine cystatin C equation is more precise, it's more accurate. So the combination is actually recommended wherever you think that there will be an issue with respect to the creatinine equation. So the current guidelines recommend that if cystatin C is available, the eGFR category should be estimated from the combination of creatinine and cystatin C. That said, creatinine is in pennies. It costs, in pennies, versus cystatin C is about like $6 to $8, depending on where you practice. It's getting cheaper over the time, but it's still not like creatinine. So I wouldn't say go and measure cystatin C in everyone. So pick and choose the appropriate patients you want to. One other situation that even though they may be healthy, where I would consider them, is this borderline kidney function of 55 to 60. If your creatinine-based eGFR shows you a GFR of 55 to 60 or 65, do they have kidney disease or not? That question always pops up, creates anxiety for the patient. So I would recommend that in those populations, use of cystatin C would better reclassify them into whether they have kidney disease or not. This is, again, in the past 3 to 4 years, there has been a major push. And of course, the inclusion of race factor, when the original CKD epi equation was developed to measure eGFR, it included a race factor because African-American population have more muscle mass. So should you consider that? So there was an approximate estimation of including race as the factor to consider. However, there have been like several efforts to take away that. And in 2021, the National Kidney Foundation and the American Society of Nephrology jointly put an effort to facilitate the removal of race equation from the eGFR. So the currently available CKD epi equation that you all see in the computer, it's more than likely not to have that race fudge factor. The most important thing what happened was when those things were taken away, some people's GFR went down, some people's GFR went up, and thankfully we're in 2025, those things we have passed that. But again, this is the CKD epi equation that's been widely recommended, including the cystatin C calculation. This race variable is not being included anymore. So majority of you being either, focusing on primary care or other specialist, how do you get involved and when do you refer patients to the nephrologist? I'm a believer of this is not a cutoff, like, oh, refer everybody below 30, refer everybody below 45. But if you look at the spectrum of kidney disease going as the GFR goes down, now the field has moved on to measure the risk. I earlier talked about the use of prevent equation to calculate the cardiovascular risk. Can you do something related to that to assess kidney failure risk, which is kidney failure meaning ending up on dialysis or transplant? Yes, we do have a kidney failure risk equation. I'll show you in the next slide. But what it tells you is like you can use that kidney failure risk equation. It's been a very well validated equation tested in several million population across the globe. And certainly developed from a Canadian population, validated first in the US and then spread it all over the globe now. If you have a kidney failure risk of like 3 to 5% at 5-year risk, then I would say definitely start referring those patients from primary care to nephrologist. And if your risk goes up at 20 or more than 10% at 2-year, like if their 2-year risk is more than 10%, you certainly want to start engaging other professionals, start to talk to them about like they may need dialysis at some point. And you have to start working on the access, which is the AV fistula or AV graft, and start talking to them about the kidney transplant if their kidney failure risk is over 40% at 2 years. So that's the general recommendation. Not set in stone. Yeah, you can tune it as it fits for your practice, but that's the thing. So what is this kidney failure risk equation? So one of the main recommendation, if you look at it's 1A in parenthesis in the top, for people with CKD G3 to 5, that's the GFR less than 60, we recommend using an externally validated risk to estimate the absolute risk of kidney failure. You can just Google kidneyfailurerisk.com and you see that it pops up. You enter their age, their sex, their eGFR, and the urine albumin. It asks you, so there is a 4-variable kidney failure risk equation, and then there is a 6 variable also. You can add additional variables if you have. Those are bicarbonate and phosphorus and so on. But these 4 variables, which most patients should have, it should show you like this little picture that you see below. Once you enter, click, calculate, it gives you their stage of kidney disease, which is not, something intuitive, however, but you see that 2 years and 5 years. When I put in a 65-year-old female with a eGFR of 28 and an albuminuria of 400 milligrams, you see that at 5 years, they have a 25% chance of reaching dialysis or kidney transplant. So this is a fairly useful tool to tell someone, which improves, apart from anxiety sometimes, but it improves their adherence to medications, understanding the disease process, explaining to them that kidney disease is silent most often. You do not get any kidney pain. It's the multitude of symptoms like fatigue, weakness, shortness of breath, leg swelling, which may or may not people attribute this to kidney failure all the time. It helps to counsel patients and adhere to medications, adhere to follow-up, and so on. So kidneyfailurerisk.com or Google, you should be able to find this out. So Here is an overarching. Again, it takes a village to to put somebody on dialysis truly, because it's not just the patients, it's their family, it's the vascular surgery team, it's the social worker who places them in the dialysis unit, and then getting them to the kidney transplant, the primary nephrologist, and we also would have to have the primary care physicians in this. So you could see as the risk goes up, all your teams on the left side gets involved. And what do we do at different stages of kidney disease is noted on to your right, like in the G1, start talking about the cardiovascular risk reduction. In G3, G2, you start to tackle those complications and promote self-management skills, start talking about kidney disease, kidney replacement therapy options when their GFR starts to go down below 30, more so below 20, and then prepare them as they are below 20 into starting dialysis, or refer them to kidney transplant centers. Whether you have doubt if they would qualify or not, I would encourage them, at least refer them. It's easy to get a hear and no rather than miss that opportunity for the patient. Here are some of our work from the past. The top one is a Annals of Internal Medicine piece we wrote, specifically focusing on diabetes management in kidney disease out of the KDIGO guidelines. And then the bottom one is the one that I talked to you earlier on. This is the 2024, specifically CKD, both diabetic and non-diabetic kidney disease topics were covered. So the primary thing is this one. This is the figure that just captures everything that we talked about in the two guidelines that I stated above. Is the fundamental things are the lifestyle, the healthy diet, physical activity, no smoking, take care of your body weight and be in the optimal body weight range for your height. Those forms the foundation, following which the SGLT2 inhibitors now have become the first drug therapy for most patients. And especially if they are albuminuric, they are the critical foundational piece along with ACE and ARB. You also see that if they are hypertensive, we recommend the systolic blood pressure less than 120. This is a contentious topic again. There is no strong evidence whether 120 or is it 130 for people with kidney disease, even though the sprint trial showed that people less than 120 had a better outcomes, and that outcome was not modified by the presence and or absence of kidney disease. So we still favor the lower the better with respect to blood pressure, and use ACE inhibitors or ARBs as a first target for hypertension in this population. And I will not go in detail today, but age over 50 plus kidney disease is considered as a cardiovascular risk factor, and unanimously the statins are recommended for all CKD population aged over 50, whether they have diabetes or not. And less than 50, again, depends on the other risk factors. If they have diabetes, then of course, yes. And if they don't have diabetes, then you look at other risk factors and then consider initiating statins. This is supported by very well conducted clinical trials dedicated to kidney disease population. So I'll come back to many of these things as we move along, but this is a flow chart that shows you how you approach lifestyle interventions. What does this say? There is so much focus over the past maybe 30 decades. The first trial of modified diet in renal disease, the so-called MDRD study, was focusing on lowering the protein intake. Even the knee-jerk response to guiding somebody about diet with kidney disease is, hey, control your protein intake, which is not substantiated in early stages of kidney disease. The MDRD study population had a GFR less than 30, which showed that in people with advanced kidney disease, lowering their protein intake would have benefit. However, in people with GFR above 30, there is no evidence out there. So the field has moved to maintaining a protein intake. It is a balance of like protein malnutrition versus slowing the progression of chronic kidney disease. As I mentioned, many of the people in stage 3 do not reach dialysis, but rather die of cardiovascular disease or protein malnutrition. So we recommend that maintain the protein intake. Do not encourage them to take high protein intake, of course, But in people with diabetes and kidney disease, you don't need to go below 0.8 per gram per kilogram per day to prevent the kidney function decline. Again, we also encourage that focus on plant proteins rather than animal proteins. There's very limited number of studies, but these are more so a consensus statement in line with all other chronic disease population. What about sodium intake? It's been, again, a major focus. We know that decreasing the sodium intake certainly decreases both systolic and diastolic blood pressure. But where does evidence stand with respect to how that translates to clinical outcomes? There's some moderate quality of evidence for decrease in the cardiovascular disease and stroke, that you lower the sodium intake, it leads to better cardiovascular and stroke outcomes. With respect to kidney disease outcomes, the high quality clinical trials are certainly missing. Despite that, we recommend, as I said, it's a 2C, meaning it's a weak recommendation. We suggest that people limit their sodium intake to less than 2 grams of sodium per day, and especially if they have underlying diabetes. And it's a C, meaning 2C. It's a suggest based on a very weak evidence. So what about the ACE and ARB? And again, these drugs have been in use for over now 3 decades, since our 4 decades, I would say, 1980s, ever since the first captopril study that was published in 1980s. The recommendation currently is that if they have albuminuria, if patients have albuminuria, whether they are diabetic or non-diabetic, you would see that there's a strong recommendation that non-diabetic, non-dialysis dependent CKD with UACR more than 300, diabetic, non-dialysis dependent CKD with UACR more than 300, then it's a strong recommendation. But in the less than 300 group, the evidence is fairly, I would say, weak. So they say, yes, suggest. You have alternate option if you're focusing on blood pressure, but if you're focusing specifically on albuminuria, I would say then lean on ACE and ARB. One common question that always comes up within the ACE and ARB use is like, they start the medication, when do I monitor? So this is a nice flow chart that we have included to guide primary care and other specialists. Like when I initiate ACE and ARB, when do I monitor serum creatinine? Within 2 to 4 weeks of starting or changing the dose, you measure. If they are normocalemic, if they have less than 30% decrease in eGFR, you either continue to increase the dose of ACE or ARB to maximize the benefit, because most of the drugs that I'll talk about in the next slides, where all these trials and newer trials were conducted on the background of maximally tolerated ACE and ARB. So if you don't want to miss out the opportunity of maximizing what has been shown to benefit the patients, the question is like, what if they develop hyperkalemia? Do not rush and start ACE and ARB, please. And we do have several newer agents that have come into the market that prevents or treats the hyperkalemia and help us to continue the ACE and ARB. If you have hyperkalemia, then review the concurrent drugs, advise to moderate their dietary potassium intake, adjust their diuretics, add sodium bicarbonate if they have underlying mild metabolic acidosis, which is always common in patients with CKD. And potassium binders, there are 2 binders out there commercially available, Patoromer and sodium zirconium cryosilicate. There are 2 commercially available out there. And this would help you to continue the ACE and ARB and maintain the cardiovascular benefits that are associated with this. The question is, what if they develop an AKI or more than 30% decrease in eGFR before again you start? Correct if they have underlying volume depletion. If you have to lower their diuretics, you do so. Consider if they have underlying renal artery stenosis before you do adjust to their ACE and ARB. The question a lot of times also comes to nephrologists is like, what is the hemoglobin A1C target that we have to use for people with kidney disease? Should I be aggressive? If their GFR is 30, if I can control their hemoglobin A1C, still would they benefit? Such kind of questions come up. So in the guidelines, we tackle this. This is a 1C, meaning it's a strong recommendation. However, it's based on a reasonably weak evidence. And we recommended in the kidney disease guidelines that it's a fairly wide hemoglobin A1C target that we're recommending for diabetic population with CKD. And why is that? Because most of our patients are old. you got to balance the issues that are noted here. Number one, the severity of CKD, the risk of macrovascular complications, underlying comorbidities, their life expectancy, hypoglycemia awareness. Do they have access to managing the hypoglycemia if they develop? And what is the possibility of them developing hypoglycemia, and what is the propensity of treatment? So for example, someone with 80 years old living alone, who doesn't have a very long life expectancy, but also more than likely to have more comorbidities, living alone with risk of, like, if they develop hypoglycemia, then there is no one to help. So we encourage in that population a higher hemoglobin A1C target, someone with a 45 or 50 who has a longer life expectancy, who certainly could identify hypoglycemia, we encourage to the left. So it's a fairly a wide range. However, we would encourage that to individualize to the patient that you're treating. This is old medications. First we tackled what are the anti-hyperglycemic therapies that are available out there. Metformin, the widely used drug both in the United States and across the globe. The recommendation is in those with GFR above 30, we still recommend continuing to treat patients with metformin as the primary treatment options. The most important thing is that if their GFR is less than 60, you certainly want to monitor their GFR more closely. And there is a detailed outline of like what dose to choose, when do you monitor, and so on. When do you think of the GI side effects? All those things have been clearly outlined in the guideline. But I want to specifically just focus. If you have a patient on metformin above 60, do not worry, continue. They're fine. If they are between 45 to 59, I would say continue the same dose, but consider dose reduction if they have other issues that you have faced or other risk of lactic acidosis, but at least measure their kidney function every 3 to 6 months to ensure they're not declining fast. And if their GFR is 30 to 44, the recommendation is to half the dose, at least cut their dose into half, and continue to monitor their every 3 to 6 months. Especially now you have more options to treat those patients with other agents that have shown to impact on cardiovascular disease. That brings us to the most important drug that has evolved over the past decade, because the first trial or subgroup analysis of a trial to show that SGLT2 inhibitors offer kidney disease protection from the EMPA-REG was published in 2015 in the New England Journal. But this little cartoon here shows you how the SGLT2 inhibitors offer kidney and cardiovascular protection. This is from a JACC review paper several years ago, showing you that SGLT2 inhibitors induces natriuresis and glucosuria. The glucosuria certainly helps us to control the glycemic aspects and also may have some benefit with respect to weight loss. But the natriuresis component offers the blood pressure lowering. It reduces the volume overload, and the tubuloglomerular feedback, which I don't want to go into today. I don't want people to log out and go out of Zoom, leads to intraglomerular pressure reduction. This reduction in intraglomerular pressure, which is the primary way in which the kidney fibrosis and kidney inflammation, everything that happens, the bad things that happens in the kidney, is the way that the SGLT2 inhibitors offer benefits. There's also benefits with respect to lowering the oxidative stress, less kidney fibrosis, less inflammation, less tubular destruction, and less glomerular damage that have been reported in both experimental and human studies, offering the kidney protection, therefore also cardiovascular risk reduction. So this formed the foundation in which it started. So where do we all stand with respect to guideline? You look at the ADA scientific statement ADA statement on standards of care for diabetes management. Look at AHA, cardiovascular, or especially heart failure guidelines. They all recommend SGLT2 inhibitors for those populations. So in people with kidney disease, if they have underlying diabetes, it does not matter whether they have albuminuria or not. If their GFR is about 20, you have strong evidence, it's a 1A recommendation to treat them with SGL2T, sodium glucose cotransporter 2 inhibitors in this population. So if they don't have diabetes, then what do you do is if they have underlying heart failure, then again, it's an indication that they should be treated with this. In the absence of heart failure and in the absence of diabetes, if they're non-diabetic, no heart failure, but if they have CKD, unless their albuminuria is more than 200 milligrams or so, then the recommendation is you don't need to use it. But if they're albuminuric, then of course you have to use the SGL2 inhibitors in this population. So where does this all evidence comes from? So this is a meta-analysis published a few years ago that pulled all the studies that, as you can see, there are at least 80,000 people who have been studied with this drug in clinical trials. And this is only diabetes. What I'm showing you here is only diabetes, and I'll talk about the non-diabetics in a minute. But you can see that among these 80,000 patients or so studied, there is a 38% reduction. So the relative risk was 0.62, meaning 38% reduction in kidney disease progression, measured as a GFR decline, kidney, more than GFR decline of 30% or 40%, doubling of serum creatinine or reaching dialysis. So that's the biggest benefit that we have seen in decades ever since the ACE and ARBs were introduced in 1980. So there was a dry period for about 30 years with respect to kidney disease treatment. And here comes the first one. So following this, there were at least two large trials that have been published. One is called DAPA-CKD. The other one is called EMPA kidney trials. These two trials have clearly shown that whether patients with kidney disease have diabetes or not, the use of SGL2 inhibitors certainly improves kidney outcomes and cardiovascular outcomes. So now the evidence is pretty clear in all CKD, presence or absence of diabetes, the benefits are consistently about 30% reduction in kidney failure risk and also an improvement in cardiovascular risk. There have been concerns when the SGL2 inhibitors came into market in 2010s that do they increase the risk of AKI? The answer is no. It in fact reduces the risk of AKI. This is again the meta-analyses wherein all the drug trials have been pooled. It showed that there was a 21% reduction in the risk of acute kidney injury when you initiate and continue SGL2 inhibitors. There are certain practical management consideration which has been discussed in detail in these guidelines that I showed you earlier. What about prolonged fasting and surgery? Are people with critical medical illness? It is reasonable to withhold this population to prevent the development of ketosis in this population. So certainly among hospitalized patients, if you have a reason to stop it, you certainly could do. If you are managing somebody as an outpatient, and if their creatinine bumps, if they're on thiazide or loop diuretics, I would recommend that adjust the dosing of diuretics even before you meddle around with the SGL2 inhibitors. And I'll show you some data from our centers on why that is important. When you initiate these drugs, discuss with them about the risk of volume depletion, any urinary tract symptoms or urinary tract infections. These drugs are not without side effects. Certainly they do have side effects. Remotely Fournier's gangrene and all those side effects have been reported. Certainly advise them, counsel them that there could be the common things being urinary tract infections or other infections that come along. One thing is the reversible decrease in eGFR. Many of the kidney protective medications, ACE inhibitors, ARBs, SGL2 inhibitors, non-steroidal MRAs, mineralocorticoid receptor antagonists that I'll talk next, they all, when you start the medication, there will be a reversible decrease in the eGFR, which is just purely hemodynamic. It's the auto-regulation of the intraglomerular pressure that happens with these medications. When you start, yes, the number goes down. However, you continue, you will start seeing that the number would be better than somebody who's on placebo. So the question also comes up is that when the SGL2 inhibitors are started, and if their GFR, if their when they are started, if their GFR is 25, should I stop it below 20? No, the answer is at least until they are started on dialysis, you can continue SGL2. So the question again next is, what about dialysis and kidney transplant? We have large trials that have been initiated or ongoing. The community can anticipate these results in 2026, whether in dialysis patients where no drug for any condition have showed mortality benefit, whether SGL2 will offer mortality benefits, we'll know next year. Until then, we cannot continue the SGL2 inhibitors on dialysis because we don't know the metabolism of these drugs in this population very well. Kidney transplant recipients, again, there are some large good observational studies showing potential benefits, but their interactions with other immunosuppressive agents is still not clear. Now, moving on, this is the mineralocorticoid receptor antagonist. In people who are already on ACE and ARB, in early 2000s, there have been a push to study mineralocorticoid receptor antagonists. The so-called aldosterone escape phenomenon. When you put people on ACE and ARB, the aldo levels suppress, the proteinuria goes down, but after sometimes the aldo level comes back up, supported by experimental and clinical evidence, and the proteinuria benefits subsides. Or they improve, but they do not continue to improve. So in that population, should we use spironolactone, which has been studied in 15, 20 years ago. The albuminuria improves. However, the spironolactone led to increase in potassium concentration, more ER visits. So that went off of favor. Now, there has been some developments in non-steroidal MRAs, which specifically focusing on kidney and heart. A drug named finerenone has been now shown to benefit in people with eGFR over 25 and have normal serum potassium concentration, but with albuminuria. They're on maximally tolerated dose of RAS inhibitors. This drug has shown that there is a cardiovascular and kidney benefits. The drug came with a black box warning, especially not black box, but actually a guidance. Do not initiate if their potassium is more than 4.8 as a cautionary note. But the evidence is pretty robust. There are two large trials with about 13,000 patients. This is called Fidelio and Figaro studies that have shown there was an 18% reduction in the kidney composite outcomes when you start these agents. We don't know whether this benefit would be on top of SGL2 inhibitors because all those trials were conducted concurrently. On someone on ACE and ARB, you start SGL2, there is a benefit. On someone on ACE and ARB, if you start non-steroidal MRAs, yes, there is a benefit, but is there an additive benefit on ACE and ARB plus SGL2 plus non-steroidal MRA, which are being tested right now? Until then, I would say start SGL2 inhibitors. Certainly, if they cannot tolerate or they cannot be on those medications for various reasons, I would use non-steroidal MRAs. And on SGL2, if they continue to have albuminuria, certainly non-steroidal MRAs is another option here. There are lots of details that we have also provided. For the sake of time, I'm going to skip here. The next focus is the GLP-1 receptor antagonist in patients with diabetes and CKD. Now this has become more so focused. There's glycemic targets. If there's somebody is on metformin and SGL2, we recommend that you use GLP-1 RAs. We also included the different CKD dose adjustments based on it. But the most important one is 6 months ago, we had the first outcome trial that came out. This in New England Journal focusing on semaglutide in kidney disease population. And it clearly showed that similar to the other patient population in people with CKD and diabetes, use of semaglutide led to improvement in kidney outcomes, composite outcomes of both kidney and cardiovascular, anything that you can think of, it showed benefits. Of course, there were some side effects, but that has been noted in other population, but definitely weight loss, kidney disease, and cardiovascular progression has been there. So there have to be some consideration. Again, nephrologists are not used to using these agents at the moment. We have provided specific guidelines. In this guideline work group, there were endocrinologists. So they helped us to craft these, how to tackle the gastrointestinal side effects. We have provided some specific flow chart, how to approach this. Again, intentional weight loss is an important focus now in patients with obesity and mild kidney disease. So you would consider GLP-1 receptor antagonist for that population. This is a figure that just tells you that no one size fits all. One drug is not good for everybody. We all deal with patients who have different comorbid conditions in different combinations. When you have those different combinations, how do you tackle when somebody has high risk atherosclerotic cardiovascular disease? Focus on GLP-1 RA. If their focus is weight loss, yes, GLP-1 RA. If their GFR is, if they have heart failure, again, SGL2, GLP-1 RA. But if you want low cost, if you live in a developing country, or low cost, then you focus on sulfonylureas or other agents. So this gives you that different drugs that could be used in different settings. And I want to spend the last part of my talk focusing on, this is my own research interest, is the implementation science. It doesn't matter how well the studies are out there. And if you look at the use of ACE and ARB, it's pretty low. And this is a experience from Indian Health Service. American Indians and Alaskan Natives had the highest risk of end-stage kidney disease if you look at 1996. Dr. Narwa, who was a former NIH director, NIDDK program director, took over Indian Health Service. He optimized the management of diabetes in this population. The most important thing is that the ACE and ARB use went up from 40% to 80 to 90% between 1996 to 2015. And you can see in the top one, the risk of the rate of ESRD has drastically gone down from like 60 to less than 30 per 100,000 population. And that was primarily attributable to improvement in RASI. Yes, we know that the drug works, but if you implement that in your clinical practice at a population level, this clearly shows that there is a benefit for the community. That said, where do we stand with respect to the use of these agents? This is a paper using NHANES data that shows that, at the best, the utilization of ACE and ARB, even in those with albuminuria, is not more than 30%. This is the national data. And this is our own VA data. VA is an integrated health system, as you all know. And in people with, this is a cohort with diabetes, atherosclerotic cardiovascular disease, and kidney disease, 300,000 veterans or so. We have only 65% of them on ACE and ARBs. So we have a lot of room to go. And if you look at global data, and this is something called a CK-DOP study that shows that within the United States, unfortunately, we do the worst, that even among albuminurics, it's not more than 60% of them are on ACE and ARB, leaving about the 40%. And the reason I'm saying this is all these SGL2, GLP-1 trials, non-steroidal MRA trials that I showed you earlier were done on a background of optimized ACE and ARB dose. Without that, whether those benefits persist, we don't know. This is our own data showing that when people get discontinued on RAS inhibitors, which is common after they develop AKI or hyperkalemia, people tend to stop the RAS and they don't go back. They go into the hospital for various reasons. We stop the medications, they don't get restarted. That by itself, you discontinue them, that it by itself lead to adverse outcomes of death and end-stage kidney disease. So when the drug is being stopped in the inpatient setting for various reasons, please reconsider when they come for a follow-up visit. And question always comes up is, hey, can I use ACE inhibitors even if their GFR is in 20s? The answer is yes. We have a robust clinical trial evidence that was published. This is a New England Journal published 3 to 4 years ago that showed that if you continue the ACE inhibitors, even in those with GFR less than 20, the risk of adverse events is in favor of people who continued. It does not impair the GFR decline. The cardiovascular risk benefit still persists. So the recommendation is you can continue as long as they can tolerate the hyperkalemia. Now, what about the newer medications? There is so much racial and ethnic disparities and facility level variations that we have reported with the use of GLP-1 receptor antagonist. And I'll end with this one slide. The most important one is similar to the ACE and ARB initiation. The SGL2 inhibitors and GLP-1 RAs are now being more and more, the use is going up, certainly. However, at the same time, the discontinuations happen. We only focus on starting the drug. But if you look at this is again a VA data. We just published this actually this month. It appeared in print. If you look at the veteran population who have free access to SGL2 and GLP-1, they do not have any copay. They were started on these drugs. However, 1/3 of them get discontinued during a 1-year follow-up. And these discontinuations, and many of them do not actually being restarted, whether it is GLP-1 or SGL2, after their discontinuation. We don't know the reasons. That's the limitation of the study, why they were discontinued. However, despite this, this discontinuation was associated with death, heart failure, and hospitalizations, and many other outcomes for GLP-1. So these discontinuations are bad for our patients. And finally, I would like to conclude that CKD is a silent disease. We need early identification, which is the critical component. Please consider if you have access to measuring the cystatin C, which is a better measure of kidney function. Lifestyle modifications remain the foundation for management of CKD. Optimize the ACE and ARB dose and consider SGL2 inhibitors for all CKD, GLP-1 and MRA for diabetic CKD once they are on SGL2 inhibitors, or if they have other indications, and focus that, the optimizing the existing therapies before we go on novel clinical options. So let me pause there and I'll stop sharing and take questions. I can see people. Yeah, I can see a few hands up. Dr. Nohi? Sorry if I mispronounced.
Oh, no worry at all. Thank you very much. Very comprehensive. I'm a nephrologist as well, so excellent review. I have 3 comments. One relates to cystatin C. The second relates to kidney stones. And then the third is just curious in your opinion about nephrology as a career. So the cystatin C, there's certainly some observational evidence. I've seen it anecdotally as well in my patients with stones who are started on these newer diabetic medications, a reduction in muscle mass, which leads to a reduction in creatinine, which leads to an overestimation in their GFR. And so I think we need to be more mindful as more of these patients are on these medications. We may need to think more about cystatin C than we previously have. The second, as it relates to kidney stones, I'm sure you're very well aware, there's a lot of evidence of insulin resistance and lipotoxicity well before we see the overt evidence of metabolic syndrome. And the manifestation is kidney stones. So kidney stones are one of the earliest markers of metabolic syndrome. Yet we don't yet see them, right, included in the risk assessment models. So I think something that we do need to consider moving forward. Now, admittedly, I'm biased as my area of interest is in kidney stones. And I welcome your comments on that. But third, I love nephrology. You love nephrology. Michael loves nephrology. Why do you think others don't seem to love nephrology so much in 2025?
Excellent. So I'll tackle one by one. So first question, the cystatin C, I completely agree. There is now I didn't show clinical trial data that have shown the kidney function measurement with creatinine and with cystatin C on those who are on GLP-1 and losing weight, which is a better measure to assess the kidney function. I completely agree with you that cystatin C would be a better one. It's not yet recommended in the kidney guidelines because it's one trial that have shown that. And again, people don't have access to cystatin C at this point. But certainly in people who are losing weight, the eGFR goes up. It's a artificial bump in the kidney function that you will see. Please do not just take that for granted. Consider cystatin C as that was just discussed. The second point about kidney stones is yes, definitely you see the insulin resistance, kidney stones also predisposed to development of future kidney disease, even though that could happen in long term. It's not when you do this risk assessment and when you do consider these risk factors. We point out these things. For instance, we're in the process of drafting the VA CKD guidelines, and kidney stones is one of the common things that we have noticed because it's a high risk in that population. So it becomes sometimes a population specific, but I agree the insulin resistance is a key factor for development of kidney disease. The third, nephrology as a career. The good note, I mean, I agree the interest has waned, and partly because of the lack of innovation that happened in 20 years. I did my fellowship in 2006, and in 2015, I was still writing ACE and ARB. What did I add anything? But now in 2025, you really have an opportunity to include precision medicine. If somebody has a heart failure, I initiate SGL2 or GLP-1 or non-steroidal MRAs or a combination. How do I tackle? If I have IgA nephropathy, you have like a slew of medication. If they have FSGS, you have new medications. If you have lupus, you have new medication. That's one. The second component is, of course, the financial, which is beyond this focus for this topic or for our group, or at least for this audience. That has been a challenge. And lifestyle, that has changed. All said and done, at least if you have attended the ASN, there was a 10% increase in the applicants this year for nephrology fellowship applicants, which also led to some good outcomes for the match results that just came out in December 2024.
Very much appreciated. Thanks so much.
Ladies and gentlemen, I think we're at the top of the hour, and I would love to have at least an extra hour with Dr. Navaneethan to go through more questions, but I know that everybody's time is very condensed. So Dr. Navaneethan, thank you so very much for joining us here today. Greatly appreciate your overview of CKD, and hopefully with your push from a national perspective, we could get even more emphasis on really looking at CKD nationally and being able to reduce the rates of end-stage kidney disease. Thank you very much, everyone. Have a wonderful rest of the day. Be well, everybody.
Excellent. Thank you so much.
Thank you. Great job.
Thank you.